Welcome to this audiobook on viral hepatitis. Just the facts. It is an enveloped RNA virus. There are approximately 2,500 new cases annually in the US. Infection occurs through person-to-person transmission via 1. the fecal-oral route, and 2. through contaminated food or water. Its incubation period is 14 to 28 days. Its symptoms usually last less than 2 months, but can last as long as 6 months. They include 1. abdominal pain, jaundice, pale stools, dark urine, and loss of appetite. It is considered an acute and not chronic infection. Chronic hepatitis is defined as inflammation of the liver lasting greater than 6 months. It is much more severe in adults versus children. It can also be transmitted through sex or IV drug use. Let's now look at risk factors for hepatitis A virus. It can be contracted through A. travel to or living in an area with poor sanitation or lacking safe water, B. men who have sex with men, C. recreational drug use, D. direct contact with an infected person. This applies to those living in same home and sexual partners of infected people. E. clotting factor disorders, and F. working with non-human primates can also lead to infection. G. most outbreaks have been due to homelessness and illicit drug use. Pause the video and scrutinize the table. We will now look at serologies. A. Total hepatitis or antibody is not useful for acute infection diagnosis. B. Diagnosis is established by the detection of serum IgM hepatitis or antibodies, which indicates whether there is current, recent, or acute infection. This will be detectable at the onset of symptoms and peak during early or convalescent phase of the disease, and it remains detectable for 3 to 6 months. C. IgG antibodies appear early in the convalescent phase of disease and will remain detectable for decades, which reflects lifelong protective immunity, and will always remain positive if patient was vaccinated or previously exposed to it. Pause the video and scrutinize the figure summarizing clinical course of hepatitis A virus. It replicates in the liver and is excreted in bile. ALT level will be elevated when liver is inflamed and usually higher than AST. Phase 1 corresponds to viral replication. Phase 2 corresponds to prodromal phase. Anorexia occurs here. Phase 3 corresponds to the icteric phase. Dark urine, pale stools, upper GI pain. Phase 4 corresponds to the convalescent phase. Symptoms usually resolve. Liver enzymes end up returning back to normal. Management. It is a self-limiting disease. There is need for avoidance of acetaminophen. Patients need supportive care, e.g. antiemetics, and fluids to replete volume loss from vomiting and diarrhea. Fluid replacement is the most important thing to address and to avoid anything that can be harmful to the liver. Let's now look at its prevention. This can be achieved through A. improved sanitary conditions, B. safe access to water, C. ensuring that appropriate food safety procedures are followed, and D. vaccination. This is going to be the most beneficial prevention technique, and it involves 2 doses given at least 6 months apart. Immune globulin can be administered if exposure has occurred and no vaccination has been given. A single dose is sufficient. Let's now discuss who should be immunized against HAV. This should include A. all children equal to or above 1 year of age, B. persons with travel to areas with intermediate to high rates of infection, C. men who have sex with men, MSM, D. illegal and injection drug users, either homeless, F. persons with clotting factor disorders, G. persons working with HAV-infected primates or with HAV in a research laboratory, H. persons with chronic liver disease, including HBV and HCV infected, and I. persons exposed as result of an outbreak. Pause the video and scrutinize the table summarizing available vaccines. Havrix may contain trace amount of neomycin and should be avoided in patients with known allergy to this compound. Administration considerations. Protective antibodies usually develop in approximately 95% of adults after first dose. It is an inactivated vaccine. Hepatitis A vaccines considered interchangeable. It is safe in pregnancy. Intramuscular (IM) injection should be administered in the deltoid muscle. If the second dose is delayed, series does not need to be restarted. Pause the video and scrutinize the table summarizing pre-exposure prophylaxis. Post-exposure management. A single dose of HAV vaccine or immune globulin 0.1 ml per kilogram is sufficient. B. Administer the dose as soon as possible and within 2 weeks of exposure. And now pause the video and scrutinize the table on this slide summarizing this. Pause the video and scrutinize the table summarizing incidence of hepatitis B virus infection. The rate of hepatitis B has been steadily declining due to vaccinations but did have a slight increase in 2014, most likely due to IV drug use. And now pause the video and scrutinize the table summarizing the hepatitis B life cycle. cccDNA is a covalently closed circular double-stranded DNA. Encapsulation is a critical step in life cycle that causes assembly of hepatitis B polymerase, pregenomic RNA, and hepatitis B core protein into the nucleic capsid. Most medications are aimed at blocking reverse transcription. Let's now discuss hepatitis B facts. It is a member of the Hepadnaviridae family. Percutaneous or mucosal transmission from infected blood or body fluids is the mode of transmission. Mother-to-child transmission occurs during childbirth. This virus survives at least 7 days outside of the body. Its incubation period is 75 to 90 days, range 30 to 180 days. The common symptoms of acute infection are similar to HAV. Treatment of hepatitis B infection. Acute infection requires supportive measures. Chronic infection requires antiviral therapy. Symptoms of chronic HBV infection. It is commonly asymptomatic, though the following may occur: ascites, encephalopathy, and extrahepatic manifestations such as 1. Polyarteritis nodosa, and 2. glomerular disease. Other symptoms include jaundice, peripheral edema, splenomegaly, and transaminitis. It may take years to manifest into compensated or decompensated cirrhosis. Let's now look at the risk factors for HBV infection. They include direct contact with an infected person, e.g., living in same home. Sexual partner. B. It can also occur through mother-to-child transmission during childbirth. It can also occur in MSM, occupational exposure to blood or blood-contaminated body fluids, and due to hemodialysis. We will now look at consequences of untreated hepatitis, all types of hepatitis. This can lead to cirrhosis, hepatocellular carcinoma. A 5-year survival with compensated cirrhosis is around 85%, while for decompensated it is around 14 to 35%. Pause the video and scrutinize the table. Let's look at Child-Turcotte-Pugh (CTP) score. A. It is used to assess prognosis of liver disease and estimate cirrhosis severity. B. The lower the score, the longer the life expectancy. Pause the video and scrutinize the table. 1 point is allocated based on the presence or absence of each finding. Pause the video and scrutinize the table summarizing a key to hepatitis B serologies. Initial workup, a complete medical, vaccination, family, social history and physical exam should be done. B. Serologies should be done. They are diagnostic if a. HB-ZAG, HBV-DNA, HCV-AB, HDV-AB, HIV. Therapeutic. HB-AB, HB-AG, HB-ZAG, HBV-DNA. Biochemical markers include alpha-fetoprotein, AFP, which is an alternative screening tool for hepatocellular carcinoma, HCC. A liver ultrasound is still preferred based on higher sensitivity, specificity, and diagnostic accuracy compared to AFP. Aminotransferases, aspartate aminotransferase, AST, and alanine aminotransferase, ALT, are markers of liver inflammation. They are typically elevated during acute and chronic viral hepatitis. And per AAS-LD guidelines, upper limit of normal ULN is 29 to 33 units per liter for males and 19 to 25 units per liter for females. They are used for guiding management of chronic hepatitis B, CHB, and ULN for ALT of 35 units per liter for males and 25 units per liter for females is recommended. Alkaline phosphatase, ALP, is commonly increased when bile ducts are blocked. Complete blood count, CBC. Platelet count is typically decreased with increased levels of fibrosis. Prothrombin time, PT, or international normalized ratio, INR, are commonly elevated in advanced liver disease due to reduced production of coagulation factors. Bilirubin. Its elevation is commonly due to red blood cell hemolysis or blocked bile ducts. Serum albumin and/or total protein. It is commonly decreased in severe liver disease or malnutrition. Gamma globulins. Hepatic ultrasound. Fibrosis markers. They can be classified as non-invasive or invasive. 1. Non-invasive e.g. fibroscan measures stiffness by velocity of vibrations from the skin that bounce off the liver, unreliable in obese, elderly, presence of ascites, or a metabolic syndrome, fibrosia, blood test that uses serum fibrosis markers in order to generate a score, APRI-AST divided by normal limit of AST, then multiply by 100, then divide by platelet count to generate a score. 2. Invasive, selected cases e.g. liver biopsy. Pause the video and scrutinize the figure summarizing hepatitis B serologies, acute infection. Pause the video and scrutinize the figure summarizing 11. Hepatitis B serologies, chronic infection. Pause the video and scrutinize the figure summarizing interpreting hepatitis B serologies. Pause the video and scrutinize the figure summarizing phases of chronic hepatitis B, CHB. Pause the video and scrutinize the figure summarizing when to initiate HBV treatment, HB-AG+. Pause the video and scrutinize the figure summarizing when to initiate HBV treatment, HB-AG. Pause the video and scrutinize the figure summarizing recommended time frames for follow-up with patients with HBV not receiving treatment. Pause the video and scrutinize the figure summarizing preferred for HBV treatment initiation, nucleoside analogs, NAS. Pause the video and scrutinize the figure summarizing guideline recommended HBV treatment initiation. Let's now look at their mechanisms of action. A. Nucleoside or nucleotide analogs. They are intracellularly phosphorylated. This inhibits hepatitis B viral polymerase, blocks reverse transcriptase, and reduces viral DNA synthesis. B. Pegylated interferon alpha. 1. Its exact mechanism is unknown. 2. It is believed to interfere with virus entry, virion uncoating, transcription of viral RNA into proteins, and assembly of nucleocapsids. 3. It may augment cell-mediated immunity. 4. It produces higher rates of HBeAg and HBsAg loss along with a durable response. Let's now compare nucleoside or nucleotide analog therapy versus pegylated interferon alpha, PEG-IFN. Nucleoside or nucleotide analog therapy. It has the following advantages: A high barrier to resistance with entecavir and both tenofovir formulations. B. Long-term efficacy. C. Safety profile. D. They are the only treatment option in case of 1. Decompensated liver disease, 2. Liver transplants, 3. Extrahepatic manifestations, 4. Acute or severe chronic exacerbation, 5. Prevention of reactivation in patients receiving immunosuppression or transmission in those with high viremia. Pegylated interferon alpha, PEG-IFN. 1. It has the following advantages: A. There are no concerns for resistance. B. It has a finite duration of treatment, that is 48 weeks, and C. It provides long-term immunologic control. 2. It has the following disadvantages: A. There is variability of response, and B. It has numerous adverse effects. Research comparing TAF versus TDF in chronic HBV infection. TAF is non-inferior to TDF at weeks 48 and 96 in CHB based on HBV DNA. There is no resistance in either TAF or TDF. There is a significantly higher rate of ALT normalization with TAF for HBe-Ag positive patients. There is a higher rate of seroconversion at week 96 compared to 48 with both TAF and TDF. For HBe-Ag negative, minimal decline from baseline in HB SAG, with either TDF or TAF. Tenofovir alafenamide, TAF1. It has lower dosage requirements. 2. It has lower systemic exposure. 3. It has fewer renal and bone effects. 4. No dosage reduction is needed until CrCl is below 15 ml per minute. Tenofovir disoproxil fumarate, TDF. Fewer drug-drug interactions, such as with the patient in previous question that was being started on RIPE therapy. Pause the video and scrutinize the tables summarizing HBV treatment adverse effects and HBV treatment drug interactions. Pause the video and scrutinize the tables summarizing current FDA-approved product prescribing information. Let's now discuss discontinuation of HBV therapy. A. Nucleoside or nucleotide analogues. 1. When there is confirmed HBsAg loss with or without HBsAb seroconversion. 2. In non-cirrhotic HBe-Ag positive patients with chronic HBV and stable HBe-Ag seroconversion plus undetectable HBV DNA plus completed at least 12 months of therapy. 3. In selected non-cirrhotic HBe-Ag negative patients with long-term virologic suppression, that is equal to or longer than 3 years, as long as close monitoring is maintained. 4. When higher rates of relapse occur with discontinuation of therapy. B. Pegylated interferon alpha, PEG-IFN. It should be discontinued after 48 weeks. Causes of hepatitis B virus reactivation, HBV. It can occur in the following scenarios: A. Receipt of chemotherapy, solid organ or bone marrow transplantation, and B. Receipt of immunosuppressive therapy, during the use of 1. Rituximab, 2. High-dose steroids, and 3. Anti-tumor necrosis factor, TNF agents. Other causes of hepatitis B reactivation include, C. Discontinuation of HBV agents, especially if co-infected with HIV. D. Co-infection with HCV. During treatment with direct-acting antivirals, DAAs, there is a boxed warning. E. It can be spontaneous. F. Reactivation could result in development of secondary symptoms related to the liver and could lead to death. G. Risk of HBV reactivation. Pause the video and scrutinize the table summarizing the risk of HBV reactivation. We will now briefly discuss antiviral resistance. A. The risk factors include, high baseline HBV DNA, slow decline in HBV DNA, and prior suboptimal treatment with nucleoside or nucleotide analog. B. We should perform genotypic resistance testing in multi-drug resistance. C. Entecavir, TAF, and TDF have high genetic barriers to resistance. D. The resistance spectrum is as follows: the level of resistance in lamivudine is greater than adafovir, which is in turn greater than entecavir, which is also greater than that of TAV or TDF. Pause the video and scrutinize the table summarizing managing antiviral resistance in HBV. Let's now consider TAF, tenofovir alafenamide. TDF, tenofovir disoproxil fumarate. 1. We may switch to another monotherapy option. 2. We may add another agent to existing treatment. 3. Emtricitabine also provides HBV activity and exhibits cross-resistance with lamivudine. 4. Drug no longer available in the U.S. We will now consider HIV and HBV co-infection. A. There is accelerated progression to cirrhosis, end-stage liver disease, and hepatocellular carcinoma, HCC. B. We should initiate antiretroviral therapy regardless of CD4 count. C. Treatment should be for both HIV and HBV. A fully active antiretroviral ARV regimen should be used in this scenario. D. Agents with activity against both HIV and HBV include the following: 1. Tenofovir, both disoproxil fumarate and alafenamide. 2. Lamivudine, which exhibits cross-resistance to emtricitabine, and 3. Emtricitabine, which exhibits cross-resistance to lamivudine. Let's look at some single-tablet regimens used in treatment. 1. Atripla, which contains efavirenz, tenofovir disoproxil fumarate and emtricitabine. 2. Biktarvy, which contains bictegravir, tenofovir alafenamide and emtricitabine. 3. Complira, which contains rilpivirine, tenofovir disoproxil fumarate and emtricitabine. 4. Delstrigo, which contains doravirine, tenofovir disoproxil fumarate and emtricitabine. 5. Genvoya, which contains elvidgravir, cobicistat, tenofovir alafenamide and emtricitabine. 6. Odifc, which contains rilpivirine, tenofovir alafenamide and emtricitabine. 7. Strabid, which contains elvidgravir, cobicistat, tenofovir disoproxil fumarate and emtricitabine. Let's look at medications that should be combined with additional ARVs. 1. Descovy, which contains tenofovir alafenamide and emtricitabine. 2. Truvada, which contains tenofovir disoproxil fumarate and emtricitabine. G. If a patient is living with HIV, we must add in a third agent with the TAV, TDF and emtricitabine to make sure there is a full antiretroviral regimen. We will now discuss choosing between HBV therapies. A. When there are no comorbidities, decompensated cirrhosis, HBV, HCV co-infection, nucleoside-naive, we can use entecavir, TAF or TDF-B. Among elderly patients with a risk of pre-existing bone or renal disease, use entecavir. It is preferred in CRCL is less than 15 ml per minute. A less expensive generic is available. TAF is preferred in HIV, HBV co-infection where there has been prior nucleoside exposure. B. Its use is not recommended if CRCL is less than 15 ml per minute unless patient is receiving chronic hemodialysis, HD. TAF should be administered after HD for those receiving chronic HD. Pause the video and scrutinize the table summarizing antiviral therapy choice with comorbidities. Who should be immunized against HBV? Everyone. A. Patients having sexual activity with or residing in the same home as a person with HBV. B. Patients with equal to or more than one sexual partner. C. Infants, DMSM. E. Injection drug users. F. Patients receiving hemodialysis or with end-stage renal disease. G. Patients with HIV, AIDS. H. Patients with jobs involving contact with human blood. I. Patients with chronic liver disease. J. Patients less than 60 years old with diabetes. K. Patients who live or travel for more than 6 months a year in areas where HBV is endemic. L. Patients who receive care in a sexually transmitted diseases, HIV testing, or drug treatment clinic. M. Prisoners. Pause the video and scrutinize the table summarizing single antigen HBV vaccines. Administration considerations. There should be intramuscular administration. B. Post-vaccination serologic testing is recommended, in patients receiving hemodialysis, in immunocompromised patients including HIV, among sex partners of HB-SAG positive persons, and in infants born to HB-SAG positive women. C. Booster doses may be required and administered if anti-HBs levels fall below 10 million international units per milliliter, among patients receiving hemodialysis, and among immunocompromised patients. We will now consider HBV vaccine non-responders. A. Risk factors for non-response include 1. Vaccine factors, dose, schedule, vaccination site. 2. Age equal to or greater than 40 years. 3. Male gender. 4. Obesity. 5. Smoking. And 6. Chronic illness. B. Management. 1. We should repeat a second series of 3 doses. 2. Patients are given doses on a schedule of 0, 1, and 6 months. 3. They should retest 1 to 2 months after repeat HBV vaccination. 4. If there is still no response, check HB-SAG. HBV post-exposure prophylaxis. Administer it within 12 to 24 hours after exposure. Pause the video and scrutinize the table. Global prevalence of hepatitis C virus. A. Dark areas equals higher rates of infection. B. 2011 to 2015 had increased due to opioid epidemic. And now pause the video and scrutinize the map. Pause the video and scrutinize the map summarizing worldwide distribution of HCV based on genotype. Let's now consider hepatitis C life cycle. A. Involves viral entry followed by B. Uncoating and translation, C. Viral replication, and lastly, D. Viral assembly and release. We will now look at hepatitis C facts. A. It is a single-stranded RNA virus in the Flaviviridae family. B. 2.4 million people in the U.S. have chronic HCV. C. 15 to 25% of those with HCV clear the virus without treatment. D. It is acquired through percutaneous transmission, among injection drug users, among those who received donated blood, blood products, or organs prior to 1992, via needlestick injuries, among those born to HCV-infected mothers, among those who have sex with an HCV-infected person, and among those sharing personal items with infected blood. Let's now look at recommended testing for HCV. It is recommended among the following: A. Those born between 1945 and 1965, who are 5 times more likely to have hepatitis C versus any other population. B. Injection drug use, current or prior history. C. Intranasal illicit drug users. D. Receipt of clotting factors prior to 1987, or blood transfusions, solid organ transplants prior to July 1992. E. Patients undergoing hemodialysis. F. Incarceration, current or previous. G. Known exposure to person with HCV. H. HIV infection. I. Patients with signs or symptoms of liver disease. J. Children born to mothers with HCV test after 18 months of age. We will now look at symptoms of HCV. Acute HCV. Patients are commonly asymptomatic but may experience mild symptoms, fatigue, abdominal pain, poor appetite, jaundice. Chronic HCV. Patients are commonly asymptomatic. It is typically insidious over several decades but can progress to cirrhosis, and HCC, HBV and HIV co-infection can accelerate the progression of liver injury and are often associated with poor outcomes. Pause the video and scrutinize the table summarizing HCV testing and diagnosis. It relies largely on antibody testing and viral loads. Pause the video and scrutinize the figure summarizing chronic HCV infection. Fluctuating ALT levels indicate varying times when there is liver inflammation that occurs. It typically takes 10 to 11 weeks to detect hepatitis C antibodies, and usually remains positive for life. Hepatitis C RNA can be detectable 1 to 2 weeks after exposure. We will now look at goals of therapy for HCV. A. To reduce all-cause mortality and liver-related adverse health outcomes, including end-stage liver disease and HCC. B. To achieve sustained virologic response (SVR), which can be considered as 1. A marker of cured infection. 2. Undetectable viral load (HCV RNA) at least 12 weeks after completing treatment, and 3. Undetectable viral load considered equal to or less than 25 IU per milliliter or lower. Let's now look at treatment recommendations. A. All patients with chronic HCV infection should receive treatment due to mortality benefit. B. Exceptions include those with a short life expectancy that cannot be lengthened with HCV therapy, liver transplantation, or other therapy. Pause the video and scrutinize the table summarizing monitoring parameters. Pause the video and scrutinize the table summarizing a continuation of the monitoring parameters. And now let's discuss determining severity of liver disease. A. Features of liver fibrosis. 1. Fibrosis is a common sign of chronic hepatitis. 2. Chronic inflammation causes the production and accumulation of collagen and extracellular matrix proteins. 3. Fibrosis is a precursor for cirrhosis. B. Non-invasive, minimally invasive methods may include 1. Physical exam of liver. 2. Blood tests, CBC with platelet count, liver panel, bilirubin, INR, AST to platelet ratio index, APRI. 3. Serum fibrosis marker panels, e.g., FibroSure. 4. Liver imaging like ultrasound, or CT scan. A. Ultrasound is useful for HCC screening every 6 to 12 months. 5. Transient elastography, e.g., FibroScan. A. Measures liver stiffness to determine level of fibrosis. B. Results can be confounded by factors such as obesity, alcohol consumption, ascites. And now let's discuss invasive methods. Liver biopsy. A. It determines amount and pattern of scar tissue collagen in the liver along with severity of inflammation, hepatic steatosis, or HCC. B. Metavir and a shark fibrosis scores derived from biopsy. C. It is considered gold standard for diagnosis but is limited by its invasive nature. D. Metavir fibrosis scoring. OPRI 1. Patient's AST or ULNAST1 x 100 divided by platelets 10 power 9 per liter. 2. Less than 0.5, rule out significant fibrosis, Metavir F0 F1. 3. Greater than 1.5, rules in significant fibrosis, Metavir F2 F4. 4. Greater than 2.0, probable cirrhosis, Metavir F4A. Commonly accepted value for this equation, 40 units per liter. Pause the video and scrutinize the two tables. Pause the video and scrutinize the table summarizing a guide to oral HCV medications. Pause the video and scrutinize the table summarizing 2. Direct-acting antivirals DAAs. Sofosbuvir. A. Drug class. It belongs to the NS5B. nucleotide polymerase inhibitor class. B. Available formulations include 400 mg tablets, and it is also available as co-formulated products, Epclusa, Harvoni, and Vosavy. C. Its standard dosing is 400 mg orally daily. D. Dosing in renal, hepatic impairment. 1. No dosage recommendations available in patients with CRCL less than 30 ml per minute (ESRD) or HDE. Administration considerations. 1. Give it with or without food. 2. It is contraindicated in pregnancy and male partners of pregnant women when used with RBV. F. Side effects reported in combination with other antiviral agents. They include fatigue, headache, insomnia, pruritus, rash, hematologic, in combination with RBV, G-drug interactions. 1. It is contraindicated, with amiodarone, symptomatic bradycardia may occur. Carbamazepine, modafinil, oxcarbazepine, phenobarbital, primidone, rifabutin, rifampin, rifapentine, tipranavir. Ribavirin. A. Drug class. It is a nucleoside analog. B. Mechanism of action. 1. It inhibits viral replication through viral protein synthesis inhibition. C. Available formulations, various brand and generic formulations. 1. 200 mg tablets or capsules, brand and generic, 400 and 600 mg tablets, brand, 40 mg per milliliter oral solution, brand. D. Standard dosing is weight-based. For patients weighing equal to or above 75 kg, the dose is 1,200 mg daily in divided doses, while for those weighing less than 75 kg, the dose is 1,000 mg daily in divided doses. 2. In post-liver transplantation, certain instances in decompensated cirrhosis start at 600 mg daily and increase as tolerated. E. Dosing in renal, hepatic impairment, based on formulation. 1. For CRCL 30 to 50 ml per minute, alternate 200 mg and 400 mg every other day using the brand Copigis. 2. For CRCL less than 30 ml per minute and ESRD requiring HD, 200 mg once daily using the brand Copigis. 3. For CRCL less than 50 ml per minute, Ribitol is contraindicated. F. Administration considerations. 1. It should be given or taken with food. 2. It is contraindicated in pregnancy and male partners of pregnant women, and in patients with hemoglobinopathies. G. Side effects. They are numerous. 1. Hemolytic anemia, teratogenic, therefore 2 forms of birth control must be used during therapy and 6 months after its completion. 2. Anorexia, fatigue, headache, insomnia, nausea, hematologic, pulmonary dysfunction. H. Drug interactions. Azathioprine, increased myelosuppression, monitor closely. Pause the video and scrutinize the table summarizing managing ribavirin toxicity. Elbasvir co-formulated with grazoprevir, marketed as Zepotir. A. Drug class. An NS3/4A inhibitor, co-formulated with an NS5A inhibitor. B. Available formulation. Elbasvir 50 mg co-formulated with grazoprevir 100 mg tablet. C. Standard dosing. 1 tablet orally once daily. 2. It is used for genotype 1 or 4 infection. 3. Treatment usually lasts around 12 weeks. Unless there is resistance, we may need to extend treatment to 16 weeks and weight-based RBV should be added. D. Dosing in renal or hepatic impairment. 1. It is contraindicated in liver impairment, child Turcot, Pew Class B or CE. Administration considerations. 1. Give it with or without food. 2. In genotype 1A patients, test for NS5A resistance-associated polymorphisms prior to treatment. F. Side effects are reported in combination with sofosbuvir. They include fatigue, headache, nausea, and ALT elevations. G-drug interactions. They are numerous, refer to package insert. It is contraindicated when patient is taking moderate and strong CYP3A4 inhibitors and inducers, and in patients with child Turcotte-Pugh class A or B. Glecaprevir co-formulated with pibrentasvir, marketed as Mavirae. A drug class. It contains an NS3/4A inhibitor, co-formulated with an NS5A inhibitor. B available formulation Glecaprevir 100 mg co-formulated with pibrentasvir 40 mg tablet. C standard dosing 3 tablets orally once daily. D dosing in renal or hepatic impairment. 1. It is contraindicated in patients in child Turcotte-Pugh class C2. Its use is not recommended in patients in child Turcotte-Pugh class B. Administration considerations. It is given with food. It can be for any genotype 1 to 6. That is the reason why it is a preferred option to use. F. Side effects, reported in combination with sofosbuvir, include fatigue, headache, and nausea. G. Drug interactions. They are numerous. It is contraindicated with atazanavir, rifampin, and various other agents, refer to package insert. Ladipazvir co-formulated with sofosbuvir, marketed as Harvoni. A. Drug class. It belongs to the class NS5B. RNA polymerase inhibitor, co-formulated with an NS5A inhibitor. B. Available formulation. Ladipazvir 90 mg co-formulated with sofosbuvir 400 mg tablet. C. Standard dosing. 1 tablet orally once daily with or without RBV. Adding RBV can be considered because it has been shown to maximize SVR rates and reducing post-treatment viral relapse. D. Dosing in renal or hepatic impairment. There are no dosage recommendations available in patients with CRCL less than 30 ml per minute, ESRD, or HD. E. Administration considerations. Give it with or without food. 2. Preferred in genotypes 1, 4, 5, and 6 without or with compensated cirrhosis. 3. Treatment duration equals 12 weeks. 8 weeks can be considered in patients with genotype 1 virus without evidence of cirrhosis, non-black, HIV negative, and viral load less than 6 million. F. Side effects, reported in combination with sofosbuvir, include fatigue, headache, and weakness. G. Drug interactions, numerous. 1. Its use is contraindicated with amiodarone. Symptomatic bradycardia can occur, refer to sofosbuvir interactions. 2. Antacids, H2 blockers, and proton pump inhibitors. A dose of less than 40 mg of famotidine or dose equivalents of other H2 blockers can be given simultaneously or separated by 12 hours. B. Antacids should be separated by at least 4 hours. C. Dose equivalents of 20 mg omeprazole or lower may be given under fasting conditions. Sofosbuvir co-formulated with velpatasvir, marketed as Epclusa. A. Drug class and NS5B. RNA polymerase inhibitor, co-administered with an NS5A inhibitor. B. Available formulation is sofosbuvir 400 mg, tablet co-administered with velpatasvir 100 mg. C. Standard dosing. Sofosbuvir 400 mg tablet co-administered with velpatasvir 100 mg 1 tablet PO once daily plus RBV. D. Dosing in renal or hepatic impairment. There is no dosage recommendations available in patients with CRCL less than 30 ml per minute, ESRD, or HDE. Administration considerations. Give it with or without food for 12 weeks. 2. It is a pan-genotypic combination. F. Side effects, reported in combination with other antiviral agents, include fatigue, headache, nausea. G. Drug interactions. They are numerous. 1. It is contraindicated with amiodarone, because symptomatic bradycardia can occur, with CYP2B6 inducers, CYP3A4 inducers, and with proton pump inhibitors, refer to sofosbuvir interactions. It is also contraindicated with antacids, H2 blockers, and proton pump inhibitors. Sofosbuvir plus velpatasvir plus varxaloprevir marketed as Vosavir. A. Drug class. 1. It is a combination of an NS3/4 inhibitor, an NS5B RNA polymerase inhibitor, and an NS5A inhibitor. B. Indication. For the treatment of hepatitis in treatment-experienced, pangenotypic cases. 2. It is not recommended for initial use. We should reserve it for patients who have failed treatment with a preferred option. C. Available formulation. 1. Sofosbuvir 400 mg tablet plus velpatasvir 100 mg plus varxaloprevir 100 mg tablet. D. Standard dosing. 1. 1 tablet orally once daily for 12 weeks. E. Dosing in renal or hepatic impairment. Use not recommended in patients in child Turcotte-Pugh classes B and C. F. Administration considerations. Give with food. G. Side effects reported in combination with other antiviral agents, like diarrhea, fatigue, headache, increased bilirubin. H. Drug interactions are numerous. 1. It is contraindicated with amiodarone because symptomatic bradycardia may occur. With CYP2B6 inducers, CYP3A4 inducers, proton pump inhibitors, refer to sofosbuvir interactions. 2. Antacids, H2 blockers, and proton pump inhibitors. Pause the video and scrutinize the table summarizing options for treatment-naive patients. Pause the video and scrutinize the table summarizing simplified HCV treatment in treatment-naive patients, all genotypes without cirrhosis. Mixed genotypes. A. They are rare. B. Data is sparse with DAAs. C. It is recommended we use a pangenotypic regimen to treat such cases. Pause the video and scrutinize the table summarizing peginterferon, ribavirin experienced treatment options. Pause the video and scrutinize the table summarizing the use of NS3 protease inhibitor plus peginterferon plus ribavirin in patients classified as treatment experienced. Pause the video and scrutinize the table summarizing non-NS5A inhibitor SOF experienced treatment options. Pause the video and scrutinize the table summarizing NS5A inhibitor DAA experienced treatment options. Pause the video and scrutinize the table. Pause the video and scrutinize the table. Pause the video and scrutinize the table summarizing HCV therapy for decompensated cirrhosis. We will now discuss viral hepatitis, HIV, and HCV co-infection. Everyone should be initiated on therapy, ideally. Realistically, the most important factor is managing the drug-drug interactions. Usually try to control HIV first and then look at hepatitis C regimen. I. Antiviral drug interactions. Albacivir plus grazoprevir. Do not use with cobicistat, efavirenz, etravirin, nevirapine, or HIV protease inhibitors. B. Glecaprevir plus pibrentasvir. Do not use with atazanavir, ritonavir containing regimens, efavirenz, or etravirin. C. Ribavirin. Avoid use with didanosine, stavudine, and zidovudine. D. Sofosbuvir. Avoid use with tipranavir. E. Ladipazvir plus sofosbuvir. Use of TDF formulation increases tenofovir levels more than TAF. Use with caution in eGFR less than 60 ml per minute. F. Sofosbuvir plus velpatasvir. 1. Do not use with efavirenz, etravirin, or nevirapine. 2. Use TDF formulation increases tenofovir levels more than TAF. Use with caution in eGFR less than 60 ml per minute. G. Sofosbuvir plus velpatasvir plus varxaloprevir. 1. Caution should be taken when taken with darunavir plus ritonavir and elvite-gravir plus cobicistat since there is no data. 2. TDF formulation increases tenofovir levels. Use with caution in eGFR less than 60 ml per minute. 3. Do not use with ritonavir-boosted atazanavir, efavirenz, etraviron, or nevirapine. In conclusion, A. Drug therapy for viral hepatitis depends on various factors such as the type of virus, antiviral resistance, presence of co-infection, lab test results, prior antiviral treatment, symptoms, disease severity, renal and hepatic function, potential for drug interactions, insurance coverage, and convenience. B. Immunization is among the preventive strategies for viral hepatitis caused by HAV and HBV. C. Infectious diseases. Pharmacists play an important role in managing drug therapy for patients with or at risk for viral hepatitis. Thank you.